Hello and welcome to Where Health Happens. I'm Mike Morland. When most people think about healthcare, they picture the professionals they see directly: physicians, nurses, therapists, and other members of the care team who work face to face with patients every day. But today, we'll be pulling back the curtain on the world of laboratory medicine and pathology to explore the people and processes that help shape patient care long before a diagnosis reaches the exam room. Joining me today are three guests who bring a unique perspective to this conversation. Associate Professor MaryAnne Stewart with Wayne State's Medical Laboratory Science Program, practicing laboratory professional Travis Reeder, and Lou Kramer, Director of Wayne State's Pathologists Assistant Program. Today we'll be discussing what happens behind a diagnosis and how this behind-the-scenes work and frontline care are essential collaborations to patient care. So before we jump into this, I just want to thank you all again for being here today. I think this is a great opportunity for people not only to get a better sense of what you do, but the fields that you work in and how all of these fields play such an important part in our overall healthcare experience. So to kick us off, Travis, can you talk a little bit more about yourself and the work that you do?
Thanks so much for having me, Mike. I'm Travis Reeder, part-time faculty here at Wayne State in the Applied Health Science program. My full-time role is as Director of Lab Operations at Detroit Medical Center. My background is in medical laboratory science. I graduated from Wayne State University here some time ago, and my background is in laboratory operations and genomics, specifically in precision oncology and in inherited disease.
All right, thanks. I'm going to kick it over to Marianne.
Hello, I am an associate professor and clinical coordinator of the medical lab science program here at Wayne State. My background is in medical lab science. I graduated from a Canadian institution that provides this program, so I have worked in healthcare settings in Canada and in the US for over 2 decades now. And today I'm educating the students that I went to school for. I specifically worked in the hospitals in hematology, transfusion medicine, chemistry, and pathology in roles of bench techs and more supervisory roles. Coming into the educational setting and having that knowledge is a good way to give back to the profession and then watch our future MLS grow.
All right, and last but certainly not least, Lou Kramer.
Hi, everyone. I am the director of the Pathologist Assistant program, as well as the associate professor and clinical coordinator for the program. I graduated from Wayne State in 2014. And as a graduate of this program, I am certified to practice in surgical and forensic pathology. My field of specialty is in forensics. So I am currently also working for Forensic Pathology Services as a forensic PA. I do locums across the country. And, my goal is to open up the field in this new specialty because it is a fairly recent new track for practitioners. So my goal is to educate our students in that new scope of practice and open up the field to more PAs.
All right. So I think one of the things I want to start us with today, I think one of the unique things about the healthcare industry is that a lot of people are probably most familiar with those people that they see at kind of the frontline roles, the doctors, the nurses, et cetera. But there's so much work being done behind the scenes. I think even more so now than ever. And so I'm curious, at this point, what do you feel could be done to make the professions that you all work in more transparent?
You're right. Visibility is a problem. I've been in this field for over 20 years, and it's been a problem, honestly, that I've been battling since I graduated. Most people don't know that 70% of all medical decisions are driven by test results that are generated in the laboratory. So whether it's the PAs graduating from Dr. Kramer's program, or the MLS students graduating from Mary Ann's program, or this AHS program that we have now that's driving students into other directions, including both of those. Most people just aren't aware of that. It's an easy number to wrap your mind around, but also a really big one.
So I think with getting the programs or healthcare professions that aren't really seen by patients, such as nursing or physicians, out there is to really be the forefront of your program. So, in an educational setting, what we do is kind of create these interprofessional educational opportunities so we can work with physician assistants and they can understand our role and, what they need from us and what we need from them. So more advocacy in that regard. And within the healthcare setting is to create those opportunities, ask to go on those rounds, ask to go into the opportunities sometimes where there's nursing meetings and they're discussing something about a blood product or something that involves lab testing. I've been on a lot of projects that kind of advocate how much the lab is, important in creating these processes. So we just have to continue to advocate at every chance we get.
I agree with MaryAnne. I think a lot of it is education. It's not only educating our students of how we can be more visible in the healthcare system, but it's also educating the other professions that we exist and what we bring to the patient, to the healthcare team. Whether it is PAs in my particular case, or MaryAnne or Travis, where we are educating these professionals at in specific organizations, whether it is during tumor boards at the hospital on a weekly or monthly basis, or you sign up to volunteer with a professional organization in a booth at a conference. And I do a lot of educating on the PA scope of practice to physicians because many of them have no clue we exist and what we bring to the table. So it doesn't surprise me that there is this veil of who are we and what we do, because I think a lot of it stems from lack of transparency, but lack of education.
I don't think there's a single individual who's listening who has never been to an emergency room, to an urgent care, and has sat there and they're going, gosh, this is taking forever. Why is this taking so long? Why doesn't the doctor just come in and see me? But the reality is, in this kind of going back to Travis, what you're saying, there's so much work behind the scenes. All of this work takes time. And I think that's one of the things that people are just generally not aware of. What's more important, having the fastest diagnosis or the correct diagnosis? And so, with that, I was wondering if you can talk a little bit about this collaboration and aligning expectations for a patient of what this work behind the scenes looks like, why attention to detail and process matters more than speed, and how this plays into that larger healthcare picture when people aren't being diagnosed with whatever ailment they may have.
I think it's honestly a bit of a balance, and it really kind of depends on what you're presenting with or what's going on. So, every floor of the hospital has a different need, and the laboratorians serve those needs in specific ways. You come into the ED, for instance, you're presenting with symptoms of a heart attack or a stroke. We know that there's urgency to that. So we're actually balancing both speed and accuracy. They're both very, very important for that. And we have metrics. Turnaround time for our testing is a key metric in every area of the laboratory, from anatomic to clinical pathology. So I think the speed piece in that regard is actually important now. If you schedule a surgical procedure, that may be a bit of a different story. If the patient is stable, their surgical specimen is going to go to the pathologist assistants who are going to gross it, or they're going to piece it apart, and then it's going to go to the histotechnologists, who are going to prepare the slides, and then it's going to go to pathology to be read out, and that process takes a couple of days to get to a diagnosis. So it really just depends upon the needs of the patient and the clinician team that is treating that patient.
And not just that, but we also really ensure that we produce good, accurate quality results. We have pre analytical issues that we are attentive to. So we have to have the right specimen in the right tube with the right volume or the right fixative in order to be able to process that. And then it with the right temperatures or even the light considerations. Like we have a lot of those considerations before we even get to the testing part. When we're at the testing part, with some of the machines within the labs, we have to make sure not just the machine is, accurately producing those results. We're constantly testing using quality control material for normal and abnormal patients. So we have to test that on it sometimes every 8 hours, sometimes every 24 for all of the analytes, just to ensure we are producing and resulting those and making sure they're within limits before we can even result any patients. So that's the analytical portion. So we test our water, we test all of the reagents, we compare them to other labs. We have an external lab program across the nation that makes sure that we're not trending in a certain way that could, you know, give a false result or an elevated result that could lead to a potential treatment or misdiagnosis. And then the reporting aspect too. Are we providing reports that are standardized? Do we have reference ranges? Are we communicating in an interpretive way where there's a millions of lab tests that could be done that any physician could easily interpret those results because we have communicated them properly. So there is a multitude of issues that we take into consideration while we have those patient samples in our hand to be able to be confident that we are giving accurate results every time.
And some tests that we are asking as PAs, um, there's just so much new information, new testing that we can ask now, from molecular to genetics. And depending on the case, you really need to have the medical history of the patient that sometimes it's not all available to ask for the correct test or the appropriate test that we need for the particular patient. So sometimes it is not just the laboratory that is delaying some of this. It is sometimes getting the information from other settings. So we encounter that quite a bit in forensics, for example, where I might request a molecular test or a genetic test for a particular patient that then will inform the family members that there is a particular genetic trait that they need to look for and seek medical attention to. But that can take sometimes weeks on our end in forensics versus surgical pathology might be a little bit faster. But then again, we're still waiting on that clinical documentation from other providers to get the full picture.
And this may not be a easy question to answer because it's going to be a little bit broad, but what would you say has changed the most in this area of medical work in the last 10 to 20 years?
Well, I have seen the changes in molecular diagnostics, which is a more targeted approach to patient care, which is fantastic because you don't want to give, a generalized medicine for a specific condition if a mutation is different for the same type of cancer, say. So I think with that, with artificial intelligence that's coming in, that's helping with, some medical streamlining of things and documentation. I think that's a big deal with automation, we're getting a little more sensitive with what we're discovering. So we can even tell early signs of acute infection before they even result into, a full-blown sepsis. So we're getting into more specialized medicine, which I think is a very good thing.
Yeah, I agree with Marianne. For me, in my field, it's been definitely the molecular testing and genetic testing, but also the utilization of 3D printing. So that became a big a few years back for us, where we could utilize the CT scans and MRIs of a patient, put that into a 3D printer, and develop the the pathologic processes that are invading some of the organs, and then get a plan of action, both at the surgical um, operating room, but then for us as well, of what would be the best sections to get the best diagnosis for that particular case. So yes, I think the advent of AI is going to, bring in new things, but the last few years, that's definitely been molecular genetic and 3D printing for us.
I agree with both. I mean, having built my career in genomics, I've been part of the boom of personalized medicine, both in inherited disease and oncology, and the things that it has done and continues to do are amazing. We've gone from sequencing individual genes to sequencing genomes. We've gone from very targeted diagnostic measures for inherited disease to looking at entire families and figuring out what's going on with their family. And then on the oncology side, we've gotten to a point where specific signatures in your cancer's DNA are predictive for the therapies that are going to work on your cancer. And those things continue to develop over time. I mean, mass digitization has been, I guess, another piece that's come along for the ride with that, where we have in surgical pathology, you have pathologists that are able now to see the entire picture of a clinical case in digital form, which improves the speed of diagnosis. And that's also going to enable using AI to improve accuracy of some of these diagnoses.
So to pivot us just a little bit here, you all are well established in your careers and have a lot of experience. And I want to back up a little bit because one of the things that I've thought about being in the Applebaum College and just learning a lot about the different healthcare professions, especially in your case, I don't think necessarily it's a common dream as a little kid when you think, when I grow up, I want to work in a medical laboratory lab or I want to be a pathologist. So I'm curious how you were introduced to this and what drove you to want to pursue this because these are extremely important careers. And for maybe somebody who's listening who is in college right now or somebody who may be interested in making a pivot, what would you tell them and what kind of drove you to want to pursue this?
Well, I kind of found this profession by accident. I knew I wanted to go into the healthcare field. I did not want to be on the front lines speaking to patients and families. So, in looking through, I literally looked through the academic calendar to see what kind of programs were there. And I'm like, I really like lab. So, why don't I try this? And, getting into the program, what I didn't realize when I started is the breadth and the scope of all of those scientific disciplines they teach us in has made me just fall in love with the profession and just want to, I don't want to say shout it from the rooftops, but kind of talk about what we do. And we don't just push buttons on machines. Like we come full circle in our programs to talking about not just lab tests, but those diagnoses and not just those lab tests that could be diagnoses. Are they junk? Are they good? Could they be contaminated? Are they valid? Those kinds of things. So we also these results mean something to us, right? We can kind of say that okay, this interpretation could be this, disease or diagnosis, or this result doesn't really make any sense because it's really not compatible with life. So we'd get on the phone and say, I really don't think this sample is value add. Is there anything that possible IV contamination? So all of those things kind of getting into learning about the profession and falling in love with what it is just something special that I'm so glad I accidentally discovered it.
Lou, do you want to go or do you want me to?
I think you have a more serious one. Honestly.
No, I thought I was going to get into your profession. So back in the early 2000s was when CSI was really popular, and obviously I'm dating myself in terms of TV, but it was really popular. So I thought between that and then the Forensic Anthropology Center at University of Tennessee has the body farm where they do all the research for mortuary science. So I thought that I was going to get into forensics. So I did an MLS, and actually graciously gave me a tour of one of the state police crime laboratories and then introduced me to medical laboratory science. So I had never heard of it myself, but then I decided, okay, well, this is what I'm going to do. And while I never ended up going down the forensic path, at the time, genetics was using medical genetics was using similar technology. So I was happy. I was happy staying in the healthcare setting.
Well, I kind of have a roundabout way of getting here. I started by taking a cadaver lab course while I was pursuing a program of nutrition. And gosh, it was dissecting the cat that brought me here, I gotta say. So I, that's kind of sad, but it was that dissection that prompted my love for anything anatomy that then led me to a shadowing experience at the medical examiner's office. And then it was there that I was introduced to PAs, the word PA or the profession PA, which can be pathologist assistant or physician's assistant. And the PAs at the medical examiner were the pathologist assistant. And the attending physician I was working with, that first shadow opportunity I had, told me, oh, physician's assistant or pathologist assistants don't work at the medical examiner. Physician's assistant can work, and you should go to physician's assistant school. So I applied to physician's assistant. I did about a year and a half of it, and I decided I was a hypochondriac because everything a patient had, I had. So I'm like, I have that too. Oh my God. So I'm like, no, that's not for me. And it just really solidified that I like to work behind the scenes. I do not want to have anything to do with a live patient. I don't wanna take temperatures, I don't wanna see their suffering. I'm okay being involved in their treatment, in their, diagnoses behind in a laboratory setting where I don't have to be that, face to face with the patient. So that's kind of what brought me, my hypochondriac and the cat dissection.
So that leads me kind of to my next question here is, as you've been working in these fields, what would you say is the biggest misconceptions? And
I think for ours in the lab, working with a lot of machinery, a lot of people think we just push buttons on machines, but we're constantly evaluating results. We're recognizing abnormalities. We are troubleshooting. We're validating findings, and we're communicating all of these critical results with the patient floors. So we don't just push buttons. We kind of analyze, interpret, and, a part of the healthcare team beyond, just running a machine.
I'll take this one. Um, I'll take this one a step further. This is actually a misconception for other folks in healthcare. So you hear about, I'm sending this sample to the lab. I put the lab in air quotation marks. Um, we are not the lab. It is often multiple laboratories, subdisciplines. There's typically one main hub that processes specimens and disseminates them to where they are supposed to go. But uh, clinical chemistry and hematology and microbiology, cytology, histology, molecular diagnostics, those are not the same thing. They are all very specific subdisciplines of laboratory medicine, and we all have our own unique strengths and unique perspectives and tasks on how we interact within the construct of the healthcare system.
Think, one of the misconceptions, and I hear this a lot from prospective students, is that, oh, I'm a lab rat. Again, the quotation marks, that I'm a lab rat. I don't, we don't need to talk to people. And my gosh, all I feel like we do in surgical pathology is talk. We dictate, we constantly talk, describe, we talk with with surgeons, with nurses, with other lab people to get the the information we need. So that being a quote unquote lab rat, that is a big misconception. Um, because you need to have the communication skills to to get the information you need. Um, I think that's one of several misconceptions, but that always hits me when someone says that.
So then, what would you say on the flip side? What's the most rewarding part of this work?
For me, it's, I think, recognizing the importance of the lab when other professions do that. For example, um, was working a hematology shift on the afternoon shift, and this patient came in, young patient, for a bug bite, extremely tired, wasn't sure what was happening. Looking at the hematology results, this patient had acute leukemia. And that was me seeing that for the first time before a physician. The physician was just about to discharge the patient, called the
Wow.
physician right away and said, listen, we have an acute kind of leukemic state. We had a pathologist involved with our physician, and they went, "Oh my goodness, that's the last thing I was thinking for this young 27-year-old patient. Thank you so much for the lab to, go above and beyond and give us a call and make sure that, the discharge didn't happen. And then this patient got, appropriate care." And, that's just one story of like a multitude of stories that all of us do have. But like once we get recognized for some of the work that we do above and beyond just the result testing, or, giving the result is, something special.
I think mine's twofold. Most of this last portion of my career has been getting processes optimized so that we can test more patients as accurately as possible and as quickly as possible. And I personally have found it really rewarding to go from being able to process a handful of samples with one individual and maintaining that same consistency, accuracy, reproducibility, and all those metrics that MaryAnne spoke about earlier on in our conversation, and being able to run 3 or 4 or 5 times the number while putting out high quality results. It just means that we're able to have that positive impact on more patients.
Yes, I mean, being able to provide quality samples that are going to drive the diagnosis and or treatment of a patient, or potentially give closure to a family member on a particular disease state that a loved one passed from. I think that really drives me. I mean, like Marianne said, she had a great story that has happened to her. Travis, I'm sure, has similar stories. I do too. It's knowing that you made a difference. And that difference can be for one patient or can be for the entire family, because what you do matters. What you do and the precision with which you do it with and the knowledge you do it with has an impact on that patient and on that patient's family, whether it is for a treatment or a diagnosis.
So, based on this, and you all work in a classroom setting, what are you taking from your lived experiences? And then also maybe things that have evolved since you were in college and applying it to the students that you're teaching now so they can be as prepared, if not better prepared than you were 10, 15, 20, whatever many years you want to put on that.
I think seeing the full circle of how the students come into the program in the beginning and how they show up in the end and their understanding from what you have taught them to the growth. And I think the difference for me, what I found, because I graduated in 2001, is certain conditions that I do teach. Some of the recommendations, say, for just say cold agglutinin disease was, why don't you live in Florida or in warmer climates? And it's kind of gives students today a little bit of a chuckle of, did they actually tell people to do that? I'm like, I'm sure, that wasn't the treatment, but that was something that someone could have recommended to prevent, a hemolytic process. So anytime I can over my years, any condition that I do teach that I have a story with, like I have a few family members that I will bring into play because I'm also saying, listen, you're also your family or your friends' health advocate too, to say, okay, you have a knowledge and a background now, or you have a foundation, and you should be proud to say, I know what these lab results mean, and they can correlate with this, and let's go get this checked out, or let's take this a little bit further. So I think it's better that we have more understanding too in the molecular realm. So when we are teaching, we're not just generically saying this is this. We can go into the pathophysiology of why that is happening. And students get it if you can relate it to an actual body process and say, okay, this is why this is behaving that way.
100% that relatability, that story, it sticks to their minds. So I have a repertoire of stories for each disease process I teach, or for anything I cover in the class. And I utilize a lot of what I do as a practitioner, whether bringing pictures from that particular case or that particular specimen. How did I handle how does it differ from what the recommendation from the books are, and why did I do particulars, or why did I order a particular test, or why did I gross it a particular way? I think the students can relate to that, because they take it as the real life scenario. And that's how we present it, is that case study. This is what I just had this weekend, or this day at the bench, and this is what I did. What would you do? We are building that critical thinking with the students, and I think that the storyline stays with them.
I can't agree more about the shared experience component of it. It's where I found the most success uh in teaching so far myself, being newer to newer to the part-time faculty aspect of all of this. They really do seem to relate if I can pull something either from my past, whether it's somebody that I know that I've de-identified, or a patient that I've de-identified, or if I ask them, hey, have you ever had a friend or a family member who's had kidney issues or a heart attack or something like that? And then just kind of start working with them. It becomes the learning piece becomes more mutual, and mutualism seems to help. I think the only piece that I would add in terms of what I've observed from these students versus when I was in college 20 years ago, uh, their brains seem to have a knack for looking at things holistically, which I can appreciate. There's a high level of concern with things that are regarding mental health. So if you can kind of loop in, if you can kind of branch out, I try to branch out from whatever I'm talking about to look at a patient at a holistic level and every single thing that's kind of maybe going on with them. They really seem to relate to that pretty well, which for medicine, I think it bodes well for their future.
So, how does communication and compassion matter in your roles, and how are you teaching that to your students?
So we're kind of teaching it as every specimen is a person, right? So if we treat every specimen like we would want to be treated, right? We kind of have to remember the compassion aspect. You have family members, friends, or yourselves, and you would want everyone to do the best they can every single time on your specimen. So if you have those expectations up front and you not just present the science, but you also present the empathy of what that specimen means, then I think the students will understand that, oh, yes, every one of these specimens are important. And that's why these pre-analytical, analytical, and post-analytical things are very important because they could affect the results, the treatment, the diagnosis. So we also have to teach some of those not soft skills, but we have to present it in a way where there is caring because we can't physically see the person that is suffering or the families that are worried or anxious about, I don't feel good and I'm worried this is a chronic condition.
There's a patient behind the specimen. That's it. Marianne's right. I mean, that message, I've heard that in a different way from every instructor I had when I was in college, to every mentor that I've had professionally, to any trainer that I had when I was learning a new process or whatever. That that consistent message is passed down in this field. It's easy for us to disassociate from the work because we're human, and we don't have that person sitting in front of us like the patient care team on the front line has. So that reiteration of that consistently message is critical.
Same thing, same words, constantly. Everything, whether it's a biopsy or a single organ or a decedent, it is a patient. It deserves your full attention, your precision, your, detail. So it does not matter what type of specimen or what type of case it is always the patient, and the patient is always number one. So
We're just about out of time. I feel like we could continue to talk about so many different topics. I want to thank you all for being here. But before we wrap up, if you were going to ask someone to take away one thing from our conversation today, what do you hope that sticks with them?
That behind every diagnosis is a team of people, and we are a part of that healthcare team. And that's what I would like them to take away.
There are a lot of moving parts behind every single patient diagnosis, whether you see them or whether you don't. Care is complex, it's ever evolving, and it's going to continue to do so.
behind every single diagnosis, there's going to be someone in a laboratory that did their job, and it was an integral piece of that diagnosis.
And with that, we'll end things there. Travis, MaryAnne, and Lou, thank you again so much for joining me. It was such a great opportunity to learn more about you, your industries, and the great advancements that are coming out of your field. So if you haven't checked out our podcast before, welcome. Thank you for being a first-time listener. We have some other great episodes that have come before this. We have a couple great episodes coming up in the next few weeks, so I invite you to come back. So until next time, I'm Mike Morland, and this is Where Health Happens.